Good evening, ladies and gentlemen.
Oh, sure. More.
And welcome to the Polsky Practical Personal Enrichment Series. I'm Emily Fowler. Tonight's program is titled How Healthcare Reform Affects You, Your Parents, and Your Children, and features three special guests. We have David Wilson, president of AARP Kansas, on this end of the table. In the center, Myra Christopher, president, Center for Practical Bioethics. And on the end, Elaine McIntosh, president, KC Hospice and Palliative Care. Before we get started, I'd like to request that you turn off any pagers, phones, Blackberries, noisemakers, so that we don't disturb people around us. Thank you. The Polsky Practical Personal Enrichment Series is underwritten by the Norman and Elaine Polsky Family Supporting Foundation within the Greater Kansas City Community Foundation in partnership with Johnson County Community College. Tonight's program is the second of 7 in 2009, and this is our 5th year. These programs are not being offered anywhere else, and we hope you'll learn something tonight that you did not know when you got here. Our evening wouldn't be possible without Norman and Elaine Polsky, for which the Polsky Theater and this seminar series are named. Their generosity to our college and to organizations throughout Kansas City and the nation is legendary, and I'd like to take this opportunity to thank Norman, who's here tonight, and Elaine Polsky. Now I'd like to quickly take you through the packet which you were handed when you came in tonight, and we hope that you'll take this information home and share it with your friends and family. As you know, these materials will help you remember what you hear tonight. Norm tells me that we forget 75% of what we hear, so having it written down is worth a lot. So let's go through the left side of the packet. On bright green, Norman's 10 Commandments, advice on how to live a successful life, and on the back of that, My Legacy to You, Principles to Achieve Financial Independence, from Jim Stowers, the founder of American Century Investments, and on the bottom half of that, Norman's Investment Strategies. And behind that, on a mellower color of green, The Power of Kindness, and on the back of that, some kindness quotes. On lavender, the Polskys' biographies and a list of their 48 endowments on the back that support organizations in the United States and in Israel. On bright red, the Polsky series TV schedule for spring 2009, and Norm wanted me to share with you, we'll be repeating the A Salute to a Greatest Generation program, which we did last November 12 times this spring. So that's one of our classics. He likes to share that with you, so be sure and tune in when you can on Channel 17, Time Warner in Shore West, Channel 22 on Comcast in Johnson County. On the back of the bright red sheet, our schedule of seminars for this year. The next page on tan, a letter with Norman's response to the current economic situation and the actions he will be taking until the market improves. And he wanted me to mention that he does an article, every quarter, which is on the pink sheet right after that. And in the article he wrote in July of 2007 and again in August of 2008, he was advising people even then to get into cash, to get out of stocks. So we hope you took that advice, because I didn't. But anyway, moving on to pink, that is Norman's article for March 1st of 2009. And on the back of that, the big 5 mutual funds he's been holding and things he's recently sold. If you'd like to receive Norman's article, please send him 4 self-addressed stamped envelopes, and his address is at the top of the horizontal side of that pink sheet. And he'll be happy to do that, as he does for around 200 people each quarter around the country. On the yellow sheet, How Safe is Our Stock Market? A 50-year analysis of the rate of return on stock investments. Norman wanted me to remind you that over the last 50 years, there have been only 12 years with negative performance So over time, the stock market always seeks new highs. And on the back of the yellow sheet is Norman's system of weighted scores, which he uses to rank his mutual funds, and these scores are used on the pink sheet. So that is the left side of the packet. Now they mixed it up a little on me this time, so you'll find the green question cards, the survey cards, blue question cards, green survey cards in your packet as well. On the green survey card, we'd like your feedback on tonight's program, how you think things went, if you learned anything. You can also suggest future topics for us for future seminars, add yourself to the mailing list if you're not already on it, and give us your email address if you'd like to receive emails about the seminars coming up. And then the blue question card, if you have a question for our panelists this evening, we'd like you to write it on this card. The ushers will come around and pick these up during the program, or you can hand them to me, and we'll get them up to our folks on stage when the time comes. On the right side of your packet is information specific to tonight's program, and I'm not going to go into detail about that. I would like to turn it over to our first speaker of the night, David Wilson with AARP Kansas. David?
Thank you. I think we'll begin with our PowerPoint slide if we could. Thank you. It's been quite a day today. I spent the day in the Capitol. The budget hearings for the Department of Aging were today. I gave testimony to hopefully have them hold off on cuts to home and community-based services. It's not a very pleasant situation with the budget cuts that are ongoing. So today, after all that, I want to relate to you where I see as state president of a senior advocacy organization, of kind of the status of things. They're rapidly changing, and what I tell you tonight probably will be different tomorrow. So the title of my talk is The High Cost of Doing Nothing to Fix Health Care. In other words, we cannot afford to do nothing. We're going to have to do something, and it's not going to be easy. What's at stake and where we're going? Now, as wages are tightening, unemployment rises, soaring medical costs are squeezing individuals, families, businesses, and the nation as a whole. 1 in 2 Americans say someone in their family skipped pills, postponed, or cut back on needed medical care due to the cost of care. Medical expenses trigger nearly half of all personal bankruptcies, and government spending on health care programs is rising rapidly, so rapidly that it jeopardizes other priorities. Those of you that heard me in my last presentation about a year ago, there was a bunch of other statistics that are still true. Things like the United States ranks 42nd in the world in life expectancy. Yet we pay so much, but we're 42nd in life expectancy. Bankruptcies are up 164% for those 65 in the past 8 years. It is a phenomenal crisis. Wages are tightening, unemployment rising, medical costs are squeezing individuals. The president, fortunately, has promised to deal with this issue, and we're going to talk about what we can deduce at this point from his plans. The financial burden of health care will only get worse over time without action. As health care costs continue to grow faster than wages, your insurance will become more and more unaffordable. Let's take a look at what's going on here with the average, with the premiums for health care. And this little chart here, the light blue represents single family premiums, the dark blue is the family. So single individuals, family. Compare the years 2000 to 2008. Each year more and more your paycheck is being siphoned off to pay for your health care premiums, which are rising 4 times as fast as your wages. Your family's total premium, in other words, what you and your employer pay, if you have an employer paying, has almost tripled in the last 8 years, rising to more than $12,000. So if you look at the bar chart in 2000, the average individual paid, and that's in total, both employer and individual, about $2,400. Family premiums were about $6,400. And again, that's what the individual paid and the business. In 2008, it was $4,700 for individuals and $12,640 for families. Out-of-pocket costs are skyrocketing. On average, Americans like you are spending more than 10% of their family income on out-of-pocket health care costs. Our leaders failed to fix health care, and recent trends continue. Out-of-pocket costs are likely to go up as well. Everything is going to cost more, and without action on the health care system, the costs are going to be set to double in the next 8 years. Another interesting statistics, I like bar charts, so forgive me. You're paying more for the cost of uncompensated care. Now, when people can't afford to pay and they go to the hospital, they may get those services, and usually do, for free. But somebody has to pay that cost, and guess who that is? That's you. If you are paying for health insurance, it shows up in your hospital costs, and particularly in your hospital costs, you are paying for the uncompensated care. And this is one of the key discussions you will hear about health care reform is, should we mandate health care? Because if everybody had it, you would not have uncompensated care. Now, to give you an idea of how huge this is, the left-hand bar is the cost of uncompensated care of 2008. And the cost of that is $5 billion more. Okay, it's $56 billion. That's $5 billion more than the total revenues for the Microsoft Corporation in 2007. So the right-hand bar is the $51 billion. Those are the total revenues of Microsoft, the cost of uncompensated care. This is why everything costs so much. I don't mind telling you I went in the hospital for a routine test. And I'll even tell you what it was. It was a colonoscopy. It would have cost me almost $11,000 if I had no health insurance. That's the doctor, the lab, everything else. Everything was fine, of course. Fortunately, I paid more like $1,500 for that procedure. So why was it so much? I kept asking that, and what I was told is the uncompensated care, because the hospital has to assume all of those costs, that's why it's so expensive. I don't know how. I wouldn't have done it if I was on my own. If I didn't have health insurance, I couldn't have afforded to do it. So that uncompensated cost, the uncompensated care, is what's pushing up the costs for a lot of people and why you're paying so much, and particularly in hospital costs. Money spent on employees' health care insurance is money they can't go in your paychecks. You know, it's costing the employers more and more and more to provide health care insurance. And you're seeing more and more cost too. You're having to pay a larger share of that because the employers say, we can't do this. You're going to have to pay more for less coverage. Financial hardships have forced millions to turn to government help for health care. And by the way, just as a little aside, the share of Kansans without health insurance has grown 39% since 1990. Last year, 12.5% of Kansans lacked health insurance. All this is weakening our economy. It's having a big impact on businesses. It's pricing businesses out of health care. A lot of businesses are cutting their health care altogether. They're saying to their employees, go fish, go find your own health insurance. Or they're offering health insurance but offering very little assistance with the premiums. It's forcing businesses to cut costs, to shift the cost to the workers. It's causing them to have to cut raises because health insurance is costing more and more. It's also, because of these costs going up, it's keeping salaries and wages lower and reducing your spending power, and it's leaving millions of working Americans uninsured. And that's what really struck me, was the fact that a lot of people who have jobs don't have health insurance. The employer can't afford it, and the employee can't afford it either. The share of small employers offering health insurance has declined as the cost of coverage has increased. It's really pricing businesses out of the healthcare business of purchasing healthcare for the employees. The cost of healthcare to businesses has increased 140% over the past 10 years. And countless small business workers are going without insurance because 80% of their employers can't find health insurance care for themselves or for their employers. If you look between the years 2000 to 2008, the share or the percentage of small employers offering health insurance has declined from 68% to 62%, and it's continuing to drop. So it's forcing this shift. Health insurance isn't available. Health insurance is very expensive, and health care is very expensive. I haven't even talked about prescription drugs. So we have this huge gap. People who lack health insurance have a higher risk of dying prematurely than their insured counterparts. This is another pretty awesome thing. According to an Institute of Medicine report, adults without health insurance are 25% more likely to die prematurely than those with health insurance. Preventative care is certainly a big key. Workplaces are affected. The lack of access to quality care leads to avoidable sick delays, and billions of dollars are lost annually. So this is a huge, huge crisis. It's costing lives. Workplaces are affected, and poor quality health care is costing our nation too many lives and dollars and time. Now let's start talking about what's going on. I mean, I could go on and on. The statistics are awesome. In fact, I would ask a question I asked last time, never got an answer to, and probably never will. Here's the question. Why is it that we spend $6,000 per person per year for health care in the United States and still have close to 47 million people with no coverage, while Canadians spend about half what we spend, yet have longer life expectancies, lower infant mortality rates, and all their people have equal care available to them? That was a quote from the AARP bulletin back in 2007. That is a very, very important question. So let's look at our key priorities. What are AARP's key priorities in this healthcare reform? We're entering a time when I believe that we're going to deal with healthcare reform. It's a complex issue. It involves the state, because the state has a stake in all this, and some of you have heard about some of that work that's going on in the smoking bans and the Medicaid, which is partially funded by state funding, those issues. And it's a federal issue. AARP stand, and this is kind of what we are standing for right now. The priorities are making affordable health care coverage options available to everyone, especially people ages 50 to 64 who are among the fastest growing group of uninsured. Interesting thing. The people in the 50 to 64 group, they get laid off. Do you think a health insurance company is going to insure them? Probably not. It would be very hard to get, or it would be very, very expensive to get. And this is a huge gap, and it's growing worse because of the economy. So we want to make affordable health care coverage available to everyone, but we want to pay attention to this hole that's opening up and the dangers that it portends. Number two, we want to keep Medicare affordable by rewarding doctors and hospitals for quality rather than quantity of care. Okay? And we want to promote prevention and healthy behaviors. I mean, one way to control health costs is to prevent from getting ill. That might be eating, it might be exercising, it might be visiting your doctor regularly, it might be establishing a regular relationship with a doctor or other provider, and they become, and you'll hear this term a lot, your medical home. That person or that organization that knows you very well and can help guide you through the system. We want to certainly eliminate fraud, waste, and abuse. Nothing makes me madder than to see the waste and abuse that occurs in our healthcare system and for programs like Medicare and Medicaid. And finally, we want to improve care coordination for people with chronic conditions and help them stay in their homes and out of institutions. Whether it's long-term care, whether it's short-term care or hospitals, people do far better in their homes, and they thrive better in their homes. Now let's talk about health care reform in the Obama administration. And this is going to give us some clues, although it's not absolute. This is a changing picture on health care reform. It's rapidly changing, but there's some things that have occurred that are important for you to keep in your mind, and it may very well give you an idea about what to expect in the next 6 to 9 months, perhaps. First of all, the economic stimulus bill. It's called the American Recovery and Reinvestment Act of 2009, and it dealt with health care reform and economic recovery. Now, these are very closely related. I've heard from a lot of people say, deal with the economic recovery, forget about health care reform. You can't do it. They are so tied together, it's unbelievable. The health of businesses is so tied to the higher cost of health care and insurance that they're strapped. Individuals who either have jobs and can't afford insurance or can't afford to pay the co-pays or deductibles, it is all tied together. And then, of course, when people lose their jobs, there is that issue of health care. So, and surrounding all this, health care is getting more expensive. So it is a real spiral, and health care has to be dealt with. Now, this economic stimulus bill is quite controversial. I'll grant you that. The bill is a complex plan of expenditures and tax cuts with the hope of reviving a struggling national economy. Congress approved and the President Obama signed the $789 billion measure that includes nearly $300 billion in tax cuts and more than $450 billion in new spending, most of it allocated over the next 2 years. Now let's look at some more details about this, and it'll give us some insight as to how the health care system is hurting and some of the things that are being done at least immediately, if not on a long-term basis. This bill, the Economic Recovery Bill, or the American Recovery and Reinvestment Act of 2009, provides a significant increase in Medicaid spending that will help to stimulate the economy as the current economic downturn causes caseloads to rise while state revenues plummet. Well, let me explain. Medicaid is a program for people of low income to provide a wide range of medical services and even long-term care. The costs for it are shared between the state and the federal government. It is an entitlement program. The state has to do this. And the state does have control over the program in the sense that it has the ability to set the rules as to the qualifications, how much it pays. That is all set by the state. And the state, of course, can match it up to the limits that it is able to establish. Now, in that particular program, as the economy sours and goes downhill, the number of caseloads, in other words, the number of people who don't have enough funds, have to turn to Medicaid, are increasing. And yet, the state, who ultimately gets the bill for all this, their revenues are dropping precipitously. And you've all heard about the revenues that are dropping in both Kansas and Missouri. So what the stimulus bill does is provide some shoring up with federal dollars of the Medicaid program to continue those services. This act also provides essential building blocks for health care reform, setting the stage, including support for health information technology that includes critical privacy protections, health care comparative effectiveness research, nurse and primary care. One of the key problems and issues to be dealt with in health care reform is how we exchange information. Believe me, it's amazing how much is still done on paper. Packets of paper, your records go from the doctor to the nursing home to the hospital and back again, and it's a big pile of paper, and we haven't figured out ways of getting rid of the paper. When I've personally gone in for health care, I've had to give my complete record 2, 3, and 4 times over and over again. A lot of waste there. We're talking about wanting to protect people. We're also talking about comparative effectiveness research, research that doctors can use on what works and what doesn't work, what drugs work and what doesn't work. And also allowing you as the public to see this information so that you can ask intelligent questions. That's part of those building blocks. More elements, affordable health care insurance via subsidized COBRA. COBRA, which stands for the Comprehensive Omnibus Budget Reconciliation Act, is basically COBRA programs allow you to continue your health insurance that you have with your employer after you've left employment. And the problem is hugely expensive, double, triple the premiums in many cases. And so when people have lost their jobs in this downturn, they have not been able to take advantage of the COBRA legislation. And so the Recovery and Economic Stimulus Bill would help subsidize those COBRA payments so that people can afford them and stay insured. There'll be an increase in food stamps and nutrition support, very important for good health. If you aren't eating well, you're not going to be healthy. And a substantial increase in funding for transportation infrastructure projects and mobility options. You say, what's that got to do with it? If you live in western Kansas, mobility is a huge issue. And it's true even in Kansas City. How do you get to the doctor? How do you get to the pharmacy? How do you get to the therapy and physical therapy that you might need? All this is all interplayed in that. Now, the latest news, of course, involves the fact that the president has begun to tip his hand about health care reform with his latest budget, his budget recommendations for 2010. It is an outline. It's a budget for the Department of Health and Human Services, HHS, and we're going to talk about that in a minute, of $76.8 billion. It's down slightly from $78.4 billion in FY 2009, but the stimulus package included another $22.4 billion in related spending. In the budget projections that President Obama has provided, he's put in a placeholder, because we still don't know all the details yet, $634 billion in healthcare reserve fund designed to begin to help cover the cost of overhauling the healthcare system. Why can't he say specifically? Because he can't. There's too many moving parts in all of this. Now, this reserve fund has caught a lot of static, and it is referred to as the down payment on the health care reform system. It is financed in part by squeezing $316 billion in efficiencies out of the current health care system by aligning incentives towards quality, promoting efficiency and accountability, and encouraging shared responsibility. The reserve fund is also financed in part by rebalancing the tax code so that the wealthiest will pay more. The budget will require higher income senior citizens in the Medicare drug program to pay higher premiums. Again, that's higher income seniors. So there are some very controversial parts to all this. Now, one good thing, of course, as we all know, is that Governor Sebelius has been appointed the secretary of this huge agency, the HHS, Health and Human Services. I think that's a good idea. I think she will be very good at it. It's probably going to be the most difficult job she will ever have, that a lot of people will ever have, in reforming the healthcare system. But it has to be done. The last attempt at major healthcare reform was 16 years ago. It didn't seem like it was that long, with President Clinton. But his approach was very different from what President Obama has done. President Clinton kind of pulled together a plan in a little bit of secrecy and then said, here it is. President Obama has taken a very different approach. He's approaching it in a very open way. You may have heard about and read about the healthcare summits. He's just had the second one. And that's a good sign. You're going to know what the plan is, but it's not going to be an easy thing, because there'll be parts in it that some people will like, some people won't. The real problem with this, though, is partisan politics. You know, the Republicans don't like this, the Democrats don't like this, and we get gridlock, and we've got to break that gridlock. Finally, President Obama said healthcare reform is no longer just a moral imperative, it's a fiscal imperative. Now, my final comments are, whoops, that's not my final comment, one more page. Some initial comments just quick things. Number one, don't listen to rumors. I'm amazed at the number of people that will come up to me and say, I heard that we're all going to have to pay double the taxes. And this is from an individual that probably is at or below any poverty levels that you could possibly imagine. There's so many rumor mongering going on. Please be careful before you form judgments. There's just so much rumors going on. Second thing, in terms of surviving this very, very difficult time, take care of yourself. Diet and exercise. You want to avoid health care costs, you got to take care of yourself. I know from my own part, I went out, I now exercise every day, and I'm dieting, I'm doing Weight Watchers. Yeah, I hate it. I love to eat, but I've got to do that. And it does. It really does make a big difference. Number 3, check out newer changing benefits, resources under the stimulus bill. The COBRA changes Medicaid, Social Security stimulus payments. There's a number of things in there that may benefit you depending upon your situation. Don't be afraid to call and ask for help. Area agencies on aging, if you're a senior, the Kansas Department on Aging, the SHIC program, which is a program that helps you find affordable quality health insurance and answer your questions, or other state and county programs. And why you shouldn't be afraid to do them? You paid for them. These are your agencies. You've paid for them through your taxes. Make good use of them. Now, my wife is a social worker, says, well, that's fine, Dave, but where do you find all those things? Well, there's several different ways. The easiest way is to get on the internet and get on the web and go to the state of Kansas, Google the state of Kansas, and you can look there, the Kansas Department on Aging. And you will find out about this SHIC program, that it will help you sort out Medicare, Medicaid, Part D prescription drugs. That's what they're there for. They'll also show you where the area agencies on aging. And you can pick up your telephone book and you'll find the area agency on aging. These are wonderful resources. They're great agencies. They work really hard, and they're there for you because you paid for them. Don't be afraid to use them. Number 2, check out AARP. I'm proud of AARP. AARP has lots of information. If you haven't been to the website, you need to be, and there's lots of good information there. And finally, vote, be informed, and speak out. I think this last election was a great example of that, but the best thing is you've got to be informed. Take the time to read. Visit the AARP website. There's lots of information there about health care reform and health care. And be involved. And that's what I have to say. Now I can say thank you very much, and I guess we'll be available for questions towards the end.
Thank you, Dave. I think Dave has given a really good overview of what we know about health care reform at this point, but there is more unknown about health care reform at this point than there is known. What I would suggest to you is that you might want to look at the Commonwealth Fund website. Many people believe that the Obama-Biden plan is fundamentally based on a report that a commission at the Commonwealth Fund developed that's titled The Path to a High-Performance U.S. Health System, a 2020 Vision and the Policies to Pave the Way. It's available on their website, and it is free to you. And it basically is an outline of what Dave has just articulated. National health care insurance, a national insurance exchange where there would be public-private insurance pooled. It would be required that all people would have insurance, much more focus on primary care and in particular a medical home, more evidence-based determinations about reimbursement and bundled payment mechanisms, increased use of health information technology, and population health policies to promote health and wellness. I think many of you would find it interesting because some of you will know him, that Dr. Jim Mongan, who was formerly the CEO of Truman Medical Center here in Kansas City, was the chairman of the Commonwealth Fund Commission. It's a very well thought out document. I think it's about 25 pages, but there is an executive summary, and so I would encourage you to read it. I want to talk about health care reform in a more narrow way tonight, though. I want to talk about a narrow but a very essential piece to reform. Last week, Jim Mongan was speaking before the Greater Boston Chamber of Commerce, and I'm going to read a small quote from his remarks to you. Jim said, as the economy worsens and unemployment and government budget deficits grow, exploding healthcare costs are becoming a hotter issue than ever. One of the very biggest challenges today isn't medical or fiscal. It's the ethical challenge of when to let life end. End-of-life issues will become even more significant as medicine advances and society ages. I think he nailed it. Medical care at the end of life currently consumes 10 to 12% of our entire healthcare budget, our entire expenditure on healthcare. If you look at just Medicare budget, just the Medicare budget, it consumes 27%, almost a third of the entire Medicare budget. Now, confounding this is that my generation, the baby boom generation, I'm one of the oldest baby boomers alive, have just begun the last chapter of our lives. The Centers for Disease Control, with whom my organization, the Center for Practical Bioethics, has been working the last 5 years, estimates that by 2030, the number of people who are 65 or older, that is, those who are eligible for Medicare, and the population most likely to die, will double to nearly 72 million people. Now, you do the math and imagine the cost implications to the healthcare budget. They're staggering. If we continue to provide end-of-life care as we do now. For more than 2 decades, my organization, again, the Center for Practical Bioethics, has worked diligently to improve care of the seriously ill and dying and their families. And we've worked on it from virtually every aspect. We've done national health policy reform. We've had the privilege of working with AARP. We've worked on it at the state level. We've done a lot of work with Kansas City Hospice. It's really a privilege to be here tonight with Dave and Elaine. And we've worked on it from an individual perspective. We've done education, advocacy. I think we've about done it all. It is my opinion, now this is my opinion, not the Center's opinion, that we absolutely must have national health care reform. 16 years ago, actually 20 years ago, I was co-chair of a commission in Kansas called the 403 Commission, where we tried to do health care reform in Kansas at the state level with former Congressman Bill Roy from Wichita. Dr. Roy and I worked on that together for 3 years. When President Clinton was elected, all the states had commissions. They all fell like a house of cards because the state legislators, frankly, didn't have the political, or maybe it was the moral will, to follow through with the work that had been done. They wanted to give that to the federal government, and we know what happened with that effort. But just as much as we need national health care reform, we must have educated consumers. And that is something that AARP has done a wonderful job of, is trying to empower people with information to accept responsibility for making informed choices about health care. I think choices about end-of-life care are particularly important, and not just from an economic perspective. I think they are so important because of the experiences of individuals and their families. But we are not there. Over and over again, for all the right reasons. And by that I mean people who are trying to make good decisions for those they love. I see families making choices that end up in nightmarish scenarios for their loved ones and result in permanent damage to the family unit because of the conflict that emerges in that phase of life. The orientation or the bias of the American public is that more health care is better health care, and that the more expensive care is, the more excellent the care is. And at the end of life, the data just does not substantiate those beliefs. It is not true. And in fact, the reverse is most often the case. We know what Americans want at the end of life. There are mountains of data. There are dozens of studies studies about this issue. And the good news is that the data holds true across social, cultural, ethnic, and economic lines. At the end of life, people want to be at home if they can be. They want their pain controlled. They want their symptoms managed. They want to be treated as whole persons, not as the cancer in room 433. They want to be treated with dignity. They want to know that their family will be cared for, that they're not an undue burden on their family, and that their wishes are honored when they are known. Sounds a lot like hospice to me, Elaine. Yet, because our physicians have had poor training in this area and have a very, very difficult time delivering bad news, and because our reimbursement mechanisms are so screwed up, they are all but perverse around this area, and because we desperately want to hold to these false beliefs that more is better, that expensive means excellent, most people in our country still get the opposite of what the vast majority of people say they want. The majority of people in this country still die in intensive care units, isolated for long periods of time, separated from their family, from their pets, from their treasured belongings. Many, many are unconscious at the time of death and unconscious for long periods of time. Of those who are conscious, most of them are in pain. We can manage pain. But of those who are conscious, most of them are in pain at the time of their death. We have got to do a better job than this. I believe, and there again is substantive data to support this belief, that the key to reversing this situation is empowering the consumer. It is getting families to talk directly about these issues and getting individuals to name durable powers of attorney for healthcare decisions. In your packet tonight, we have provided to you a document called Caring Conversations. This is a document that actually AARP helped us to pilot in 15 states. It is a document of the Center for Practical Bioethics. I'm not here to sell you this document. There are many, many good tools. It is on our website and it is free. So if I was selling it to you, I wouldn't make much profit on it. But it is a tool to help families have these difficult conversations. We know that sometimes the most important conversations are difficult conversations to have. So we have created this tool to hopefully help families, and when I say family, I mean intimate connections, intimate relationships. I don't mean necessarily blood kin, to have these conversations. I know that when families have had conversations and when difficult decisions have to be made, that families aren't out in the hallway of the ICU unit fighting over, did mom love me most or you most? They aren't fighting over what mom said she wanted. They know what mom said she wanted, and I hear over and over and over again what a gift my mom gave me or what a gift my dad gave me by doing this, and that we had the peace of mind of knowing that we were doing what he or she wanted. Conflict arises when these conversations have not happened, but when they have, and the conflict have occurred, and conflict arises, people can go back to those conversations and kind of recalibrate and say, now let's get refocused here on what Dad said he wanted, or what Mom said, or what Uncle John said. And let's try to focus on what we do to respect their wishes and to honor the life that they lived. Now, Elaine and I recently had a glass of wine and talked about our shared work, and just one. And, I said to her that there are many, many days that I feel like, I've been working on this stuff for 30 years. There are many, many days that I feel like we've made virtually no progress, because most of the calls I get are about the bad cases. Following the Terry Schiavo case, does everybody remember Terry Schiavo? The Pew Foundation Pew Fund did a study, and even after all of that, only 30% of the adults in the United States have actually made an advance directive, have actually named a durable power of attorney, have actually had a conversation, done the thing that 85% of adults in this country say they believe is a valuable right and something that they ought to do. So we've got a big gap between what we say and what we do, and we've got to figure out how to bridge that. The economics of this may be the driver here, but I would hope that that's not the reason that ultimately do this. Last night I got a call rather late as I was getting ready to leave the office from a friend, a person that many of you in this audience may know, and she called to tell me that her father had died. I knew that her father had been ill for quite some time, and she called to thank me for the work of the center and to thank me that we had shared this document with her and her family, and that they had had the caring conversation, and that when they had gotten a call a few days ago, her dad was in California, and he had been sick for quite some time. When they got the call from a young physician telling them that her father was on a ventilator, but he believed it was not appropriate, that her dad was dying, and he thought the right thing to do was to extubate him and to allow him to die. She told him that she was her father's durable power of attorney, and that she agreed with him because her father had told her what he wanted. But she asked the young palliative care physician, which is a big word, I hope Elaine will tell you what that word means. She asked him, would it be acceptable for her dad to stay on the ventilator for 24 hours because she has 3 siblings, there are 4 children, until they could all get there. And he said he thought it would be entirely appropriate. So in less than 24 hours, they all got there. They found their father conscious. His pain was being managed. He was on the ventilator. He couldn't talk, but he could communicate with them. All 4 of them, they came from New York, Wisconsin, Kansas City, and California to be with their dad, had time with him together. Each one of them had time with him separately. Then they asked the care team asked them to leave the room. He was extubated. They had a good protocol in this hospital. He was kept completely comfortable. They all came back with him and held his hand until he died about 15 minutes later. And my friend said to me, what a gift he gave to us, because we had no question that we were doing that which honored him and that we were showing him how much we loved him. The last thing she said to me is how lucky they felt that they had done this. And I said to her, this should not be the luck of the draw. This should be the standard in our society. This should be the way that all of us live the last part of our life. Now, as I've said in your packet, you have this workbook. If you have not had this conversation with your family, I really want to encourage you to do it. I really hope you will. At the very back, there is a durable power of attorney for healthcare form. When you came in this evening, I asked people to invite you to put on one of these little paper hospital bracelets. The reason that we ask that is with the research we've done at CDC, it's like tying a string around people's finger. We know that if we ask people to wear this little paper bracelet until they've had the conversation, these are really durable. You can shower in these things for 3 or 4 weeks. That people they report to us that they wear them until they've had the conversation. Now, I've said I wish I'd been smart enough to make these out of rubber and sell them for $1 like Lance Armstrong. I wouldn't be doing all the fundraising I do day after day. But please, I encourage you to really think about how important it is and what a gift it would be to your family to have this conversation. I hope Elaine will talk more about the only thing that I could have wished for my friend's father was that instead of being at the hospital, that hospice had been involved and that he could have been at home.
Thank you, Myra.
You're welcome.
Aren't we a cheery bunch? I'm afraid it's not going to get much better at this point. But what I wanted to comment about tonight really arises out of my 30 years involved with end-of-life care. My role, I became involved with hospice in 1977 when it was very, very early, and in some respects, part of almost considers radical to be challenging the current delivery system and surfacing the question of whether or not we were doing the job we needed to be doing for people who are dying. And I think that when Myra and I shared our glass of wine, our one glass of wine, I said to her, you know, take heart. Because having done this for 30 years, I actually have seen dramatic improvement. And to some extent, I'll just briefly share with you a personal story, which has no great drama to it, but it is interesting in that it is illustrative of the past many years that we have been working in this subject matter. My father died at age 57 of cancer in 1975. He received, at that time, what was the standard of care. He was in a good hospital, he had good and caring doctors, he had the worst possible pain management regimen, which is still, unfortunately, in some places used, but he had a great deal of pain. It was not well controlled. My mother had no support. She cared for him at home by herself. She had 3 daughters in their 20s, all who knew everything there was to know about this, and were continually advising her. And he died after a few days in the hospital, really with none of us having support, the opportunity to talk about this, or frankly, any direct conversation about what was happening. It wasn't a good thing, but it was the standard of care at the time. In early 2008, my mother died at the age of 91 with great hospice care, at home in her own bed. We had 2 months worth of wonderful nursing support. We had physician home visits when she was unable to leave home and see her own physician, and she died a very peaceful, she had a very peaceful ending, which all of us felt very satisfied with. Sorrowful, of course, but it was okay. It was satisfactory, and it was how she would have written her own script. So I see, although we have our discouraging days, I do actually see great progress, and I do see that we have gotten much better at this than we were 30 years ago. But having said that, I want to make just a few comments about the issue of healthcare reform, which is before us, and describe it from the vantage point of what we see every day. I mean, our role, we see hundreds of patients every year, and observe firsthand story after story after story of the suffering, the premature death, and we see it with people who have names. We see that what we read and hear about in regard to the financial devastation that people experience after a lengthy illness is absolutely true. It happens every single day in a myriad of ways. People who become ill and are no longer able to work, they buy their insurance through the COBRA program, they live longer than the 18-month COBRA window, they run out of insurance in the midst of all of this, and they are totally uninsurable at that point. There is really no recourse for that individual. There are people who believe they are well insured, and we all know this, believe they are well insured, and so long as they aren't sick, they are. But when they do face this kind of illness, they learn what they don't have coverage for. One thing they learn, unfortunately, all too often is that a lifetime people hit their lifetime maximums all the time. Happens every day, and they are stuck. They also learn there is a huge variation in insurance coverage for probably practically everything, but what I know, of course, is hospice care. And I would venture to guess that the 2 of you probably don't have the same insurance, and the 2 of you have dramatically different coverage. It's crazy how people will ration the number of nursing visits that they allow us to make because they only have a set number in their policy. I would guess that one of you probably has coverage for personal care, for a nurse aide to come and help you with personal care, and the other one doesn't. I would bet that one of you has a pretty good prescription coverage plan, and I'll bet that another one of you does not. We see people all the time who have no prescription plan, and when you are big sick, that is huge because the cost of these medications are just enormous. So the whole subject of financial devastation, bankruptcy, when people have major illness, it's so real. It is so real. And I oftentimes think, you know, these are not people who can organize. And I oftentimes think that if the whole country knew the story of this woman and what she experienced, the outcry for a national health insurance program or something to ensure that nobody has to go through this experience with this would be deafening, because it's just real. And it can, all of us walked in, but this can happen to any of us. I also want to speak just for a moment about the idea of the uninsured getting care. To some extent, I think this is a myth. I don't think that the uninsured get care. What typically happens, or often happens, is that people who have no health insurance ignore their symptoms, delay. They may be able to afford a physician visit, but the diagnostics and subsequent treatment is really out of reach for most people. So what happens to people is they wait, a crisis happens. They end up in the emergency room, they get a big workup, they get a terrible diagnosis. They may or may not get treatment. It depends on whether or not there is a benevolent provider around. You will get cared for in an emergency room because there are laws requiring that you get cared for in emergency rooms. But there are no laws requiring that you get chemotherapy, that you get radiation therapy, that you get any other kinds of medicine. None of that is mandated. So you either attempt to self-pay for that, end up with a big bill, end up bankrupt, etc.
Sorry.
Starting over here. You want this one? So did all of you miss all that good news? Okay, is this working? Yes. Okay. So the idea, I know there's huge, uncompensated care is certainly real, but if all of the care that were needed were actually provided, the uncompensated care bucket would be far greater than it actually is. The other thing I just want to comment on in this financial sort of subject is, I don't care what anyone says, Medicare is by far the best coverage there is. People with Medicare have more choice than anyone else. They have more clarity about what their benefits are. Sometimes just finding out what your insurance covers is a Herculean task. So the idea that Medicare will inevitably change, but Medicare is the best health insurance there is. And, you know, we'll probably never see it. Us baby boomers here will probably never have that good a coverage. And I don't think I've ever had that good a coverage. But in any rate, it is a program that is sometimes maligned, but really shouldn't be. The thing that we don't often acknowledge about Medicare is it has this terrible adverse selection problem. It takes care of everybody who's old and sick. All of the young people who are not using health services are covered by private commercial insurance plans. So my observation is, in some respects, until we combine the premium dollars, if you will, that go into the pot for older people who are using all the health services with the premium dollars for all the younger people who are not using health services, we're never going to manage this economically. I know for all of us probably, whoever our insurance company was, when we were in our 20s and 30s, they made off like bandits with us. So so you have to get this money all in one bucket in order for this to begin to make some kind of economic sense. Okay, so that's all my money. That's all the comments I have to make on the subject of money. There are a couple of other things, though, that I just want to mention that affects people that we observe frequently. One is that treatment is not benign. And Myra mentioned this as well, but I sometimes wonder if that extraordinarily important conversation between the physician and the patient about the benefits and the burden of treatment ever took place. Because treatment, certain types of treatment for certain types of diseases, one, can kill you prematurely, but the other thing about it affects the quality of life. It can affect the length of life, and it can affect the quality of life, and it can affect the quality of your dying, if you will. And those things, this is a whole nother conversation, but that conversation about burden benefit with treatment is something that I just don't think happens as often as it needs to. The other comment that I'll make to some extent related to that is that the medical complexity of patients that we see continues to get more and more acute. And I can't believe I'm saying this because I've been saying this for years. But yet it continues to be true. And these patients that are sent home from the hospital with an expectation that they're going to be able to manage this and their spouse or their adult child or someone else is going to be able to handle this. I mean, it's miraculous if someone can, but the expectation that we place on lay people sometimes is just over the top. And I'll just give you a quick sort of current example. Young person, devastating diagnosis, small children at home, has a colostomy, a nephrostomy, which is a tube running through the skin to the kidney, a PCA pump, a pain pump, a feeding tube. Let me think. There's more. That's enough. That gives you a picture. And young children at home, sent home from the hospital with home care support. But this isn't something that ordinary mortals should be able to handle. But our system of support for people at home is largely episodic. Medicare, or private insurance, except in limited instances, supports someone being in your home 24 hours a day. It is mostly an intermittent support program. And there are certain kinds of things that are just too overwhelming to be cared for at home. But we see this every day, patients coming out of hospitals with these remarkably complex situations. Okay, so that's all the really depressing comments that I have to make on the subject of what's going on kind of every day. The last part of my remarks, I want to focus on this somewhat at a more personal level and a more personal preparatory level. Myra has already addressed the vital importance of having a durable power of attorney. I don't think people realize how much they give up by not having that. You give up your right to decide for yourself by not having that document. And as far as Medicare and hospice is concerned, you can't have hospice care if you are unable to speak on your own behalf. You cannot have hospice care because it's a choice, and you have to have someone who is legally authorized to make that choice on your behalf. So if you ever want to get into hospice care and you think you might just one day be unable to speak for yourself, you better get the durable power of attorney. But the thing I think everybody really needs to spend a bit of time thinking about is what we know, that most of us are not going to have a quick exit. Most of us are going to have a period of dependency of certain length, hopefully short, but in which we really are not going to be able to take care of ourselves. We are going to have to rely upon others on either an hourly or a daily basis to take care of us. And how long that is, what it's like, really depends upon, obviously, the medical condition. But there are three things that I think people need to ponder as we all think about this. The first one is the practical. How much money do I have? How liquid is what I have? Do I have long-term care insurance? Do I understand what the long-term care insurance really covers? Have I talked to my family about this, etc.? So the universe of the practical is an element of this. The second element is the universe of the medical. What do I want? How much treatment do I want? How aggressive do I want things to be? And how do I want to describe to whoever my durable power of attorney is what I really am looking for? Because it's really hard to contemplate what the instance will be. You know, you can describe, if this happens, then I want this. If that happens, none of those things will happen. Something else will happen. But the thing that has always been meaningful to me is Bill Colby's description of this, which is, I want the things that are a bridge to recovery. And if the treatment isn't a bridge to recovery, but will simply prolong my dying, don't do it for me. So it's important to think in that type of language, because you won't be able to anticipate the exact set of circumstances which may befall you where you need someone to make a decision on your behalf. Okay, that's 2 of the 3 buckets, the practical, the medical. The last one is the emotional. Nobody ever thinks about this, but it's actually an important component of this. So, so say I'm in this dependent state, and I've got all my marbles. How am I going to cope with this? What am I going to do with myself? And there are, and this is something I've learned in hearing the stories of many, many patients. People can find ways to make this a meaningful time. Do you want to write a little memoir for your family? What do you want to do when you can't move about, but you can still think? One woman once said to me, I'll never feel useless while I can still pray. And she found that was what allowed her to be gracefully in the bed and gratefully in the bed without becoming sort of miserable and depressed. A couple other comments I just want to make in regard to how to be helpful to your family when you are the one in the bed. One of them is tell people what you want. Not in terms of not only the medical treatment and other things that we've talked about, but if there's something that's important to you. If you want to go fishing one last time, you know, people can make things happen. But if you make an important memory with your family, I've seen over and over and over again, families do these crazy things together one last time. And sometimes it's a huge effort, but family take those memories with them forward forever. And so to try to surface something meaningful and rich for you and the people that you love is very important, and very important to them in the long run. We also observe every day some people accept care more gratefully and more gracefully than others. It's easy to get surly when you're in the bed, but it's something to try to remember. That the people who are caring for, I hope I'm not a surly. I know I will be someday in the nursing home, and I'm really going to be a rotten patient, but I hope I can remember how important it is to say thank you to the people who are taking care of me. To be graceful and to be grateful makes a huge difference to the patient as well as to the people that are around them. Lastly, I want to say a couple of things about sort of the mysterious, if you will. And this may be a little more out there on the edge than may be comfortable for everyone, but the other thing that we observe over and over and over again is some of the amazing things that happen as people are dying. And it's sort of this magnificent mystery. And I don't pretend any special understanding of this, but I will observe to you some of the things that happen frequently. People oftentimes appear very confused, using language that doesn't seem to make sense. But we have learned, if you tune into this language, sometimes it's very symbolic. People will have dreams, people will talk seemingly from a confused state, and if you listen closely, you hear some remarkable things. You hear over and over again travel metaphors. You hear ending metaphors, home runs, closing the deal, making the sale. And this is oftentimes accompanied by time, this week. And we find many times that this is the dying person actually telling us something about time. And I will tell you personally, my own mother had a prophetic dream. At 7 o'clock one morning, a Sunday morning, she woke and told me she had the most amazing dream, and it was about being in a car, and it was traveling, and it had a time frame, and it had an ending, and I knew because I have a trained ear, I knew she would die that week, and she died on Wednesday. So it's remarkable, these things, but they are real, and people who work in this work will observe this over and over again. I also want to say that oftentimes when people are dying, when someone is dying, everybody's gathered at the bedside, or important people are gathered at the bedside, and they sit there for hours or days or whatever, and as soon as they leave, the patient dies. This happens constantly. I only observe, there must be a point to this. And I really have come to believe that sometimes that's just what needs to happen in order for the person to let go. But people have horrible guilt experiences because they left the bedside right at that moment. So anyway, the bad news, I guess, is that we're all going to die. But the good news is we are better at this. And I just want to mention a few programs. These are programs that are offered by Kansas City Hospice that may be of use. First of all, we offer a program that's called palliative home care. The word palliative means comfort, and it is a very similar program to hospice, except without a prognosis requirement. We realized many years ago that you shouldn't have to be dying in order to get good pain management, good support for your family, good education, etc. And so palliative care is the sister of a hospice program, and it is provided for people who have a life-threatening diagnosis, but it doesn't have the prognosis expectation. People who are receiving palliative home care may be on a transplant list, may be getting active treatment, etc. It is a broader eligibility, if you will. Hospice care is provided in people's own homes and in nursing homes, as is probably well known. The thing that is the greatest dilemma for hospice is how late people come to it. Early is so important. Probably 40% of the patients that we take care of are on service with us for 12 days or less. That's crazy. All of the service that hospice provides, it's just denied what could have been there for 3, 4, 5, 6 months worth of support. The family struggled along without it. And the support is wonderful. Your meds are delivered to your home. You've got a nurse on call 24 hours a day. You've got your own nurse who comes and assesses and talks to your physician for you, etc. Hospice House is a short-term care facility for people for whom home is just not the right place. It's short-term. It's generally when people are having symptom problems or close to the end of life. Carousel Pediatric Hospice and Palliative Care is for kids from newborns up to 18. Kansas City Palliative Medicine is our physician practice. We have 5 physicians on the staff. This is all they do. They make home visits. They manage patients at the hospice house. They do all kinds of things. We have a counseling program, and we recently added a program called Solace House to the family of services that we provide. Solace House provides grief support to children and their families. I think I'm about 5 minutes over. So I'll end by thanking Norman and Elaine for this series and for all you've done for all of us in the community. And I guess we have questions now.
Great. I think our speakers have dealt with some pretty complicated and difficult topics tonight. Let's give them a round of applause. And that is evidenced by the nice pile of questions that we have here. So I'm just going to kind of dive into these in no particular order. Elaine, you had mentioned that Medicare is probably the best health care that's out there, gives people lots of choices, but we have a questioner here that says Medicare Part D, the drug coverage, is a mess. Is it on the reform consideration? Medicines are covered or not covered depending on your insurance coverage, and are there plans to make some changes in that?
You know, I am probably the least expert on reform issues, so I would defer to my colleagues on that. There is talk about doing eligibility requirements, or it is a mess, and it's much more expensive than what people had imagined, and so that's one consideration, is to do some eligibility screening.
Well, yeah, I've not heard that, but the complexity issue, let me go back to the comment about being good. It's certainly better than not having it. The problem is, you know, you have Part A, Part B, Part D prescription drug, you have Advantage plans, and then you have the Medigap plans. It is hugely complex. With Kansas, many of you had 20, 30 choices on your Part D prescription drug. We would like to see it simplified, but I don't think that's going to happen as long as the push for privatization and these types of things is there. What we would rather see, however, is good coverage, and that you can get coverage for your particular prescription drugs. That's first and foremost. Yeah, it's way too complex, and again, it has all these different moving parts, and hopefully we can simplify that. But as long as the private sector has a say in all this, there's going to have to be multiple choices. That's why we got it in the first place, is that the private sector said, well, us too, we want to be able to be a player in that. Yes, we'd like to simplify it. We'd like to make it easier. It's very cumbersome to go online. We spent untold hours on Part D workshops trying to help people sort out what their choices are. We finally got some pharmacy students, and they were great at working with seniors. But yeah, I'd like to think we can make it simpler, but I'm not sure it is. It's at least on the short term. But first of all, I want to see it be better. I want to see it cover the prescriptions you need to take.
We have 5 or 6 cards here dealing with questions or comments on socialized medicine, and everything from examples of friends who live in Canada who still aren't happy to folks that want to move there. So does anybody feel qualified to speak to socialized medicine, the advantages, disadvantages? I'm sure we might be able to do a whole program on that topic potentially.
You know, I think that it is really not going to happen in this country. The other day when there was the health summit, you may have, the first health summit, we've had 2 now, you may have heard that people in Congress who are for universal payment, another way of talking about a single payer system, socialized medicine, however you want to characterize that, and some people, the physicians group for universal health care, weren't invited to the first summit, and they threatened to picket the summit, and then they quickly got an invitation. I am a member of a health policy group that the AMA convened about 10 years ago to talk about access issues, and it's been a pretty steady group, but every year we have 1 or 2 new people who will join us, and someone every year will say, well, why aren't we talking about universal health care? And everybody kind of laughs uproariously and says, you know, Joe, take Bill over there and tell him why we're not going to talk about that. The special interest groups in this country are, quite frankly, simply, in my opinion, too powerful to allow this to happen. Plus, I don't know that the American public wants it.
Well, I'm going to disagree with that a little bit, because I think it may not happen, and AARP will take a neutral position on it. It has to at this point, but it may change. The problem, what's driving a lot of this, is that the partisan politics and the bickering that goes on, and they say, will we ever have this single-payer system? The interesting thing that's now happening is that business and industry is saying to the government, we don't want this anymore. We can't afford it anymore. And I've had a lot of businesses say, you know, maybe a single-payer system isn't so bad. If you look at the cost of running things like Medicare, they're far more efficient than the private systems we see today. Far more efficient. Now, I'm not trying to say that this will happen or that I'm an advocate for it, but you know, I think it has to be looked at with the other plans. There's pluses and minuses. I know people will say Canada, oh, it doesn't work. But you remember that little quote I said? Their infant mortality rates are lower, longer life expectancies. Some of these are measures about the quality of health care. Is it perfect? Oh, my, no, it's not. But you know, I'm not really sure. I may tend to agree that the partisan bickering is so strong it may not happen. But you know, there are people pushing towards this direction who've never pushed. And one of the biggest people is the private industry in the United States. The car makers, the other big industries who are saying, we don't want to see this run privately anymore. We don't want to have to deal with it. Please help us. And I'm really amazed at what I'm hearing in that regard. What it would look like, I wouldn't have a clue, because there's good and bad in everything. But there is more awareness now that, is this going to be real bad? Or do we need to look at it? And I think there's going to be a lot more discussion about it. Whether it'll happen, it's still pretty much up in the air.
You know, Dave, the conversation, I think, has shifted. We're not even really talking about universal access to health care now. We're talking about universal access to health care insurance now. Mm-hmm. And so I think, you know, we obviously, I think, disagree about this. I personally would like to see us have a single health care delivery system, and where it was a lot more simple for people to get in and out of and so forth. I just don't believe that it's going to happen in this country.
I think too, we're interested in seeing choice. You know, if the private systems can somehow come together and offer affordable options and good choices, you know, a choice is always good. The problem is it can go so far the other way, as we've seen in things like Part D, where it's just so complex and cumbersome, and you know, really hasn't lowered costs all that much. Yeah, choice can be fine if it can be made to work, and I'm just not sure it's worked today.
I would make just a couple quick comments on this. One is, I wish I would live another 50 years, because I think in 50 years we will have a single payer plan, because I think it's just inevitable. It's going to limp along until it gets an organizing principle around the financing of health care. But what makes sense to me is that there be at least a public option as well as private options. And the reason I think we have to have a public option, frankly, is because when you get to my age, none of the private insurers want me. I mean, you know, the private insurance market is not interested in covering people who are over a certain age or have any kind of little health history. And I'll tell you, you know, by the time you hit a certain age, you got a little health history. And it's almost impossible to get a reasonable policy if you're looking for one individually. So to some extent, I think, how can we do this and not have a public option? That opportunity for individuals to buy into Medicare early. And there's a side benefit to that, frankly, which is there are tons of people in the early baby boomer group who are really ready to retire, and they can afford to retire. But they're held hostage to their jobs by health insurance. If all those people went ahead and retired, a huge number of very high quality, high paying jobs will open up. And so my hope is that some kind of private or public option does become available for people to buy into, because it's impossible to retire and buy a reasonable health insurance policy.
And that's what the so-called National Insurance Exchange is intended to be.
But that's what we have now. You have Medicare, you have a public option, you have the Advantage plans, which are private options, if you are, you know, of retirement age and 65. And there is that, and there's Advantage plans. You can get traditional Medicare with wraparound. You have that now, and then the question is that working? The other thing is, you mentioned about people retiring. Yeah, it's nice to have them retire and turn over those jobs, but then what we run into another problem, and that is the Social Security issues, the retirement fund issues. I am going to be 65 in December. No way am I going to be able to retire. I can't afford it. With what's going on in the stock market now, all the things that have happened, I'll be lucky to be able to retire at age 70. I think that, yeah, isn't just health care. It's also the retirement issues and the Social Security issues that are also going to drive some of this. Some of it may not be bad. If people work longer, Social Security then will be more solvent longer on. So it's such an interwoven issue of the retirement and the security issues and the health care issues. Wow, is it complex.
Well, there you go. I do want to mention, I'm going to get to a question now that Myra can talk with us about regarding the caring conversations. But before I ask you the question, I do want to mention, I believe 2009 is the 25th anniversary of the Center for Practical Bioethics. So you have some special events coming up, and I think that's in your packet. So be sure and take a look at that before you leave tonight. Here's kind of a two-part question for you. First of all, when do you suggest having the caring conversations dialogue? Before people get sick or when they are sick? And how do you bring up the subject when someone thinks he or she may live many more years than is realistic?
You know, if you think about Terry Schiavo, the Schiavo case, or many of you will remember the Nancy Beth Cruzan case that was here in Missouri some years ago. Terry Schiavo, I think, was in her 20s when her accident occurred, as was Nancy Beth Cruzan. So I think when you have the conversations or when you turn 18, because in fact, maybe a little bit earlier, we actually have a program at the Center for Young Adults that's targeted towards kids who are 16 to 24, I think it is, because kids are so accident prone at that time in their life. I think a lot of people are surprised now that when kids go off to college, that the infirmary or the university health service can't give parents information about their child unless their child has a durable power of attorney and has named their parent. So I think there are a lot of reasons to do this, and I think it is really as soon as a person is mature enough to have the conversation. I think it makes a lot of sense to do this, and certainly before you get sick. I cannot tell you how many times I've had calls from someone who said, we are at the hospital. My mom is going to have surgery tomorrow morning. Now, when you enter the hospital, you're usually pretty anxious about the situation, and that's not really the time that you want to have the conversation. I think you want to have it in kind of a settled way. If you look at the document, you will notice that it says, it doesn't start out by saying, do you want to be on a ventilator? You know, who in the world would say, oh yeah, sign me up for that? It starts out by asking you about what relationships are important and what's given your life meaning and what has given your life joy and so forth. So absolutely, we think that you should have the conversation now. If you haven't had it, have it now. How do you get people to talk about this? You know, there are times, what I often hear is from people my age, they say, oh, my kids don't want to talk about it. From people my kids' age, they say, oh, my parents don't want to talk about it. So one way, you could go home tonight and say, call your kids or email them and say, you know, I heard this crazy lady talking about this stuff tonight, and you wouldn't believe it, but she said email you. But, you know, when there are these cases in the news, but another thing to do is just to say, you know, I've been thinking about this, and I really would like to have a conversation with you, and it would be very helpful if we could find some time to do this. April 16th will be National Healthcare Decisions Day. This will be the second year of National Healthcare Decisions Day. And yeah, you got it. The connection for the date, April 15th, taxes, the 16th, the only two inevitables in life. So organizations around the country have agreed that on this day, we're going to try to get people in kind of a calm, thoughtful way to catch their breath and to have conversations with their family. On our website, there are all kinds of tools. You can find buttons that say, we had the talk. You can get these bracelets. But I think that the hardest part is raising the issue. But if you say to someone you care about, I've been thinking about this, it would be really helpful to me. It would mean a lot to me if we could find a time to sit down and talk about this. Even when people say, oh, Mom, you're going to live to be 100, you say, yeah, I hope so. But you know what? None of us knows what our next day will be. So let's find a time and talk about it.
Thank you very much. Somebody actually asked if you could also repeat the website for the Commonwealth Fund.
Oh, you know,
And
I
for
don't
your
know the
organization.
address, but if you just go to Google or your search engine and just plug in Commonwealth Fund, you know, it's a nonprofit, it'll pop right up, and it's easy to find the document. I should have brought the link, but I didn't.
Okay. All right. I think that we are about out of time for this evening. Our panelists would be happy to stay and talk with you all, and I think I would like to thank them all one more time for dealing with some really interesting topics for us. We hope you'll all come back April 1st. Please go out to the lobby and have a cookie and some coffee or punch before you leave, and stay warm. We'll see you next time. Thanks for coming.